This is your lecture on CNS stimulants. CNS stimulants are a class of drugs that are going to stimulate areas of our brain and our spinal cord. So how they're going to work is acting through stimulation of our excitatory neurons within our brain. So 3 of our main neurotransmitters that we're going to be talking about is dopamine, norepinephrine, and serotonin. You're going to have 2 similarities with dopamine and norepinephrine. Those 2 are both considered sympathomimetics, meaning they're both mimicking the sympathetic nervous system. Dopamine is actually a precursor to norepinephrine. Dopamine also plays a major role in our body's reward system. That's whether we're feeling pleasure, a heightened arousal, and our learning. It can also help with our focus, concentration, also memory, mood, sleep, and our motivation. Can anybody think of a disease process that occurs due to a lack of dopamine? If you said Parkinson's disease, you are correct. That is a disease due to a lack of dopamine. Another one that most people aren't aware of is attention deficit hyperactivity disorder, also known as ADHD. Next, we have norepinephrine. Those are also categorized as adrenergics. And again, those mimic the sympathetic nervous system. So if we're talking about mimicking the sympathetic nervous system, what are we expecting to see? If you said an elevation in your heart rate and your blood pressure, you are absolutely correct. But what are some other things that we would expect to see? Well, if we think of our fight or flight, what are some things that you really want to have if you're fighting for your life? I don't know about you, but I would want to be way more alert. I want to be very focused in order to survive. So if we're lacking norepinephrine, we're not going to be able to focus. We're going to have poor attention. So our patients with attention deficit hyperactivity disorder, they would benefit from having a replacement of norepinephrine. And then we have serotonin. That neurotransmitter is going to help with regulation of our mood, sleep patterns, also anxiety, appetite, and even pain. Our CNS stimulants are going to be categorized in 3 different ways. It's either based on their chemical structure, the actual site of where site of action occurs, and then the therapeutic use. So we're first going to start talking about the overarching drugs that are going to treat attention deficit hyperactivity disorder as well as narcolepsy. So typically our first line of treatment are going to be our CNS stimulants. However, we have to be very cautious because there is a very high risk of tolerance and physiologic dependence, as well as psychologic. The great thing about CNS stimulants for treating ADHD and narcolepsy are they are going to elevate the mood, energy, alertness. They will decrease appetite, which actually can be problematic in your patients with ADHD because then that could lead to nutritional concerns. So that is another thing to be cognizant of. Back in the day, they would truly use cocaine and amphetamines. As you can imagine, that is not something that is prescribed present day to manage ADHD and narcolepsy. So we needed to create something synthetic that would mimic an amphetamine. And that's where methylphenidate came to fruition. However, due to that risk of tolerance and dependence, they have created non-amphetamine stimulants. So the main goal, especially with our patients with ADHD and narcolepsy, our goal is to increase mental alertness. So what these drugs are going to do is stimulate those areas of the brain. Those are predominantly going to be the cerebral cortex and our thalamus, because that is where mental alertness occurs. We're mimicking the sympathetic nervous system, so we're going to improve our mood, elevation of euphoria, increase mental alertness, which is one of the main goals, decreasing our fatigue and drowsiness, especially important for our patients with narcolepsy, and prolonged wakefulness. When we also think of our fight or flight, what else do we need when we're fighting for our lives? Well, we need to be able to breathe more efficiently, especially if we're running. So think of it as bronchial smooth muscle relaxation. So that's going to improve oxygenation to our lungs. So, what patients would utilizing amphetamines or non amphetamines for either ADHD or narcolepsy be contraindicated in? So, if we think of causing CNS stimulation or a sympathomimetic, what would be some patients that you would not want to use those drugs in? If you're thinking anybody with hypertension or tachycardia, so an elevation in heart rate and blood pressure, you would be correct. Now, what also happens when you have an activation of your sympathetic nervous system? Has anybody here ever had albuterol, which is a sympathomimetic? Yes, you're improving your respiratory function by relaxing your bronchial smooth muscles, but what else does it cause? It causes tremors. It causes you to be a little anxious and somewhat agitated because now your sympathetic nervous system is kicked in overdrive. So if you have somebody that already has anxiety, that would not be the best drug of choice for them. We also need to be mindful if our patient is taking an MAO inhibitor, which is also known as a monoamine oxidase inhibitor. We will be talking more about that in later topics. But you should make sure that they're not concurrently taking one. And if they are, they need to wait at least 2 weeks before taking any sort of CNS stimulant. In regard to your adverse effects, like we touched upon with your CNS stimulants, you need to make sure that you're monitoring your heart rate and your blood pressure. So if you're giving that drug, you are expecting that your blood pressure and your heart rate are going to become elevated. Tremors are also very common due to that uptick in your sympathetic nervous system. And think of insomnia. Well, of course, if you're taking a sympathetic stimulant, you're not going to be able to sleep, which is also the aim when somebody has narcolepsy. Your goal is to keep them awake. But what about your patients with ADHD? That could be very problematic. You don't need to memorize every single adverse effect, but you should know what you would expect to see should your sympathetic nervous system be activated. As the nurse, what is your responsibility to do monitoring a patient while taking any sort of CNS stimulant? Well, we always want to get a baseline. So, what was the mental state before therapy, during therapy, and what are we treating? So if it's for ADHD, we want to make sure that we have a good baseline. That's going to tell us if the patient is getting better, if their symptoms are improving, or maybe worsening. For our patients with narcolepsy, we want to make sure we have a good guideline of where their sleep patterns are at because we want to make sure it's improving. If it's not, then this may not be the best drug for them. We absolutely need to monitor for tolerance and dependence because that is highly possible. We also need to watch those vital signs very closely. If we start to see an elevation in that heart rate and the blood pressure, we need to consider maybe we need to reduce the dosage or this is not the right drug for this patient. We really have to be careful, especially in patients that already have a somewhat elevated blood pressure, because if a blood pressure gets too high, that is a very common cause of a stroke. So we would not want to induce a stroke for ADHD or narcolepsy medications. So how should we be educating our patient? Very important that we tell them to take this medication exactly as prescribed because of the risk of dependence. Especially do not take this at bedtime. So if you take this at bedtime, what's going to likely happen? Well, you're probably going to be up all night. So it should be taken in the morning. You really need to avoid taking anything really that's a CNS stimulant, especially your caffeine and your energy drinks. If you take any sort of CNS stimulant, so caffeine, energy drink with these medications, you're going to be extremely tachycardic, hypertensive, anxious with severe tremors. So they need to be avoided. It's also really important that they monitor their heart rate and their blood pressure at home. So ask them to get we call it a sphygmomanometer. That's a blood pressure cuff. You can get one online at CVS, at Costco, and every day before you take your medication, check your blood pressure. Get an Apple Watch or a Galaxy Watch, something that can track your heart rate so you have a good idea if it's getting too high. Teach them about fight or flight. Let them know what that means. And if they start to see any of those symptoms, it's likely from your medication. And maybe we need to decrease the dosage or decrease the frequency, or maybe it's not the right medication at all. So now let's dive into the drugs themselves. So, as we mentioned earlier, our first amphetamine is methylphenidate, and that is your very well known drug, Ritalin. So, that is a commonly used medication for ADHD, but we can also use that to manage narcolepsy. It is important that you are aware of your onset, your peak, your half life, and your duration so that you are aware of when you are going to see effects of that drug, when it's going to be at its highest effect, and how long that's going to last. I don't think providers or even nurses educate their patients on what that means and what a peak is so that when they get home, they know if they have a really high heart rate and high blood pressure, maybe that's the peak of the drug. So those are things I think that are important that we do educate our patients about. Our next drug, modafinil, also known as Provigil. So we use this for patients with narcolepsy to promote wakefulness and that have excessive daytime sleepiness. We can also use those in people that are working night shift. So we call that shift work sleep disorder. So I worked 12 years on night shift, and thankfully I never had to start any medications, but towards the end of working nights, it was getting really challenging being able to sleep during the day. And for those of you that either work nights, have kids, you know exactly what I'm talking about. That when you don't get sleep, how terrible you feel. It is not a good feeling. So it's really important that we are able to manage sleep cycles. When we look at our onset, peak, half-life, and duration, those are things that you should be familiar. Although with modafinil, there is an unknown duration. The onset, peak, and half-life that you see for this, those are for your therapeutic effects. And those are the only two drugs that you do need to know for ADHD and narcolepsy. Now we're going to delve into anti-migraine drugs. Something interesting that a lot of people are not aware of is that headaches and migraines are actually due to vasodilation and not vasoconstriction. When we talk about the anti-migraine drugs, we also need to be aware that they're for management and not prevention. So the drugs we're talking about are not going to prevent a migraine or a headache from occurring, rather managing the symptoms once they start. You may see some drugs, and maybe some of you that suffer from chronic migraines or headaches have taken ones that are combined with either acetaminophen, aspirin, or caffeine. A lot of your over-the-counter ones are going to be a mixture of caffeine and either acetaminophen or aspirin. So for the drugs that we are going to be discussing, how do these work? So the main thing we want to promote is vasoconstriction. So these drugs are going to stimulate those serotonin receptors in our cerebral arteries, which will then cause vasoconstriction and thereby reduce our symptoms for our headache and or migraine. We also have a mechanism where we're going to have a reduction in the production of our inflammatory neuropeptides. So our predominant usage is going to be for acute migraines and or headaches, and you can also take them when you have an aura. An aura is going to be very different for every individual person. I am somebody that unfortunately does suffer from chronic headaches and migraines, and for me, my auras are going to be a sensitivity to light. So I know that if all of a sudden I start having really bad light sensitivity, that is my aura and I'm going to get a migraine. Some people have very obscure and very acute symptoms that mimic other things. So, for one example, I've seen a handful of patients that have come in through the emergency department that are actually showing signs of a stroke. When they work the patient up, everything is negative. So they say that that's actually a migraine for the patient and an aura. So the symptoms present as a stroke when in reality, it's the onset of a migraine. So everybody's going to be very different. If somebody does suffer from chronic migraines, they'll know what their precipitating aura is going to be. So it's really important that you ask the patient, always let me know when you start to see an onset of what your aura is so that we can start treatment immediately. When we think about contraindications, we need to take into account these drugs are going to promote vasoconstriction. So if they're going to promote vasoconstriction, what do I need to be worried about? Some of these drugs may be selectively vasoconstricting in our cerebral arteries. However, this can cause vasoconstriction throughout the body. So if you have somebody that suffers from hypertension, we need to be concerned about that because we can cause an even higher elevation in their blood pressure. Additionally, if you have a patient that has any sort of history, let's say they had an aneurysm and we're worried about increased pressure within their cerebral arteries, we need to be cognizant of that because we don't want the patient to have another stroke or aneurysm. And just so you know, a stroke isn't just ischemia, like a blood clot. You can also have a hemorrhagic stroke. And the most common cause of hemorrhagic strokes is actually hypertension. So if you have too much pressure on those vessels, that causes them to rupture. So always take into account your patient's past medical history and if there's any concern with causing more vasoconstriction. In regard to your adverse effects, it's really along those same principles with vasoconstriction. So if I have any sort of disorder, like let's say the patient has peripheral vascular disease, there's already vasoconstriction and they don't have adequate blood flow to their extremities. Do I want to give a medication that's going to cause even more vasoconstriction? So anything that can promote more vasoconstriction, we need to be mindful of. Another really interesting adverse effect from our anti-migraine drugs is a tingling and flushing sensation. And I myself actually do take Imitrex, and it is a very intense tingling and flushing feeling. I already know what to expect when I take it, but it's very uncomfortable. It almost makes me feel like my blood pressure is really, really low and I'm going to pass out. So I always have to be very cognizant of when I take it because those symptoms are so uncomfortable. It is also important that you take this exactly as prescribed because if you don't, it can cause rebound headaches. So for nursing implications, what we as the nurse need to make sure that we are doing prior to giving this medication, assess the patient's baseline. What are their baseline status of their headaches and their migraines? That's going to tell us if after we give the medication, if it's getting better or if it's getting worse. We also want to make sure that we look at what precipitating factors can help the patient, whether it's eliminating or managing their headache or migraine. So a lot of times our non-pharmacologic interventions are going to be key. So non-pharmacologic interventions for a patient dealing with either a headache or a migraine, making sure that you're in a dark space. So when you're working as a nurse, you need to have a lot of light, especially if you're working on night shift. Be mindful not to go in and flip in all the lights because that could be very sensitive to the patient. Smells are another really big one. That's also another part why, as a nurse, we are not supposed to be wearing any sort of perfume, strong odored lotion. It's because that can be really bothersome to the patient, and especially if they're already feeling really nauseous, scents can really put them into overdrive. We also want to be mindful of other medications that we're giving. So just as a random example, nitroglycerin, which will be talked about later. Nitroglycerin is a medication that vasodilates, especially if somebody's having chest pain. That is your gold standard medication that you give in the field if somebody's having chest pain. So it causes vasodilation. So let's say we have to give that to our patient for whatever reason. Well, they're probably going to get a really bad headache. If they already suffer from chronic headaches and migraines, we need to anticipate we're going to need to give them their medication. So we always have to take into account medications we're giving could also exacerbate their headaches and migraines. Some other non-pharmacologic interventions, ice packs are really great. We do actually carry in the hospital ice packs. So we can fill it with ice and they can put it over their eyes, and that really helps. Or even a cool washcloth to go on the back of their neck. Another really great resource that we also do carry in the hospital is peppermint oil. So putting the peppermint oil on the patient's wrists and under their nares, that is also another way to help alleviate the symptoms of their headache and or their migraine. As far as patient teaching, we really need to encourage the patient to carry the medication on them at all times. The reason being is they need to immediately take that medication as soon as their symptoms start. So they can take one pill, okay, and then 2 hours later, they can take one additional. If it doesn't work, they cannot take any more. So it's really important that you take that immediately to try to alleviate and stop those symptoms. And really reiterating what nursing implications are in regard to evaluating what your precipitating factors are. So telling our patient, if you know what your triggers are, try your best to avoid them, especially in the acute care setting. Making sure you tell the patient, educate your nurses. Hey, this type of smell or the lights are really sensitive. Can you please make sure that you tell the oncoming nurse, don't turn the lights on. This type of sound affects me. Let everybody know so we know how to make sure that we're avoiding causing a severe headache or migraine. So now diving into the actual category of medications, we're talking about our serotonin receptor agonists, also known as SSRAs. These are our triptans. So your drug is going to end in triptan. So for example, our drug of choice is going to be sumatriptan, also known as Imitrex. So our triptans work by stimulating those serotonin receptors within the brain. How your SSRAs are going to work is through that stimulation of serotonin, we're going to reduce inflammation and then constrict our blood vessels, which will then help with our headache and migraine symptoms. The triptans can come in various formats. You can either do oral tablets, sublingual, which means under your tongue, subcutaneous injections, and nasal spray. Can you think of, out of all of the oral formularies, which one would be the fastest onset? If you said sublingual, you are correct. So sublingual is preferred because it has a rapid onset. We also have to take into account if you have a patient with a very severe migraine and they're very nauseous and possibly even vomiting, is that going to be easy giving them an oral tablet? Probably not. So then we may need to convert to another formulary because they can't take anything orally. So for our sumatriptan or Imitrex, our onset's going to be about a half hour to 1 hour with a peak of 2.5 hours. We have a half-life of 2.5 hours and our duration is going to be 4 hours. And that covers our anti-migraine medications.